Good afternoon, everyone. Today is Tuesday, February 3rd. The Senate Finance Committee today will start with a briefing on the Baltimore City Mass Overdose Rapid Response Plan. I want to thank Mayor Brandon Scott for being here. And my list says Dr. Michelle Taylor, Health Commissioner, James Matz, Assistant Chief, Emergency Medical Services, Stephanie Mavronis, Director of the Mayor's Office of Neighborhood Safety and Engagement, Sarah Whaley, Executive Director, Mayor's Office of Overdose Response, and Dr. Letitia, Deputy Mayor, Health and Human Services. What is it? DeRaza, Deputy Mayor of Health and Human Services. So thank you all for being here. We're looking forward to the briefing.
Thank you very much, Madam Chair, Mr. Vice Chair, and members of the committee. I am pleased to be here with you today to talk about this important issue. While no community in Maryland and quite frankly in this country is untouched by the opioid epidemic, Baltimore has been on the front lines of this crisis for decades. And for far too long, as was the case for public safety, our city government operated as though we could arrest and criminalize our way out of this issue. When I took office, we committed to doing things differently, taking a data-driven public health-informed approach, which included a needs assessment, a strategic plan, investment in wraparound services and support, everything from housing to workforce development, and most importantly, partnership with community advocates and partners, because we know that those who are closest to the problem are closest to the solution. This work is possible because of nearly $600 million we secured after going after Big Pharma for their role in overdose and opioid issues in Baltimore. And we're seeing the impact. Preliminary data shows overdoses fell more than 20% last year. And while one life is one too many, this tells us that our strategies are working. And I know we're here to talk specifically about our rapid response to mass overdoses. But to be clear, there is no rapid response without the intentional investment and relationship building that happened before. We were able to respond so quickly to these incidents and prevent any loss of life because our agencies had experience working together in response to smaller scale overdoses. We were able to mobilize 500 volunteers to canvass the neighborhood around Penn North, and because my office, BC Moore, and the health department had strong relationships with community organizations and advocates, we were able to go even deeper. BPD was able to trace the source of these drugs and conduct a takedown operation because of the work that my group violence unit does day in and day out. MONSE has been able to maintain a presence in the neighborhood to this very day because we have procedures in place to provide trauma-informed care and resources when incidents like this happen. The most important message I have for other jurisdictions is do not wait until a crisis happens to take action. Start laying the groundwork in your communities now. We here in Baltimore are always there as a resource. We want other communities not to just do what we are doing, but improve upon what we are doing, because every death from overdose prevention is preventable, and every life in this state is worth saving. Thank you.
Thank you, Mayor. Who would like to go next? Thank you.
Thank you, Mayor Scott. And thank you, Madam Chair, Vice Chair Haynes, and committee members for allowing us to present to you today. I'm Dr. Michelle Taylor, the Health Commissioner for the City of Baltimore. Before we dive into the mass overdose events that occurred in Baltimore City and the response protocol we developed, I want to share how we are defining a mass overdose event. This way, we can all be aligned as we walk through the event and our response protocol. Defining a mass overdose was our first step in creating the protocol. This involved making a distinction between a cluster, a definition used by EMS and our epidemiologists, and a mass overdose. A cluster is a geographic group of overdose reversals greater than expected for a given area and time, at least 3 reversals within a 3/4 mile in 1 to 7 days. An overdose reversal is a patient interaction where naloxone was administered by EMS and the patient's condition improved. Baltimore City Health Department's epidemiologists receive daily reports from the Baltimore City Fire Department, which they analyze and use to create cluster reports, which are then sent to outreach groups and city agencies to potentially inform their activities. Through consultation with EMS and our epidemiologist, we defined a mass overdose as at least 5 overdoses in a 1 to 3 hour period in a small geographic area or single location. A mass overdose triggers the mass overdose rapid response protocol that you will hear about today. We'll discuss this more later, but the protocol uses a 2-tiered system depending on how many overdoses occur. When 5 to 10 overdoses occur, there is a partial activation of protocol. When 11 or more occur, this triggers a full activation with a larger multi-agency response. This threshold aligns with the Baltimore City Fire Department's definition of a mass casualty incident. I'll turn now to my colleague, Chief Wallace from the Baltimore City Fire Department to discuss the event that occurred on July 10th.
Thank you, Doctor. Good afternoon, Madam Chair. Chief James Wallace on behalf of the Baltimore City Fire Department. So on July 10th, 2025, multiple city agencies responded, as the mayor said, in response to what initially began as a single call for a drug overdose. This incident would eventually evolve into a citywide operation that involved post-medical care, also involved a lot of outreach into the community. Next slide. So our first call was received at 09:20 in the morning, and it was actually received for a drug overdose. I would like to note at the time at which that call was received, our community paramedicine unit was actually en route to that area. They normally work in that area to distribute care packages to residents and the homeless in that area. But that call came in. When our units arrived, they began to treat a critically ill individual. That evolved very quickly. We were approached by numerous people in the area stating that there were multiple unconscious patients in a very unspecified radius around the incident itself. This incident would evolve to involve 8 basic life support units, which are EMT level transport units from the fire department, 7 advanced life support, 5 fire suppression units, plus an additional 3 units that were requested, 4 community outreach units, 5 of our EMS leadership units, our EMS command staff, as well as part of my command staff and the Office of Emergency Management would eventually deploy into this area. Next slide. We encountered overall 7 what we classify as priority 1 patients. Priority 1 patients are critical patients. Time is of the essence with them. And in fact, 7 were transported to the hospital under ventilatory assistance by our paramedics. So they were either non-breathing or they were barely breathing once they left the scene. 15 patients were classified as priority 2. Priority 2 patients are patients that are serious, that need definitive care. They need transport to higher level of treatment. So they definitely needed to be in the hospital quickly as well. And then 5 priority 3 patients. All of these patients were revived or resuscitated to some degree with Narcan. Overall, we transported 27 patients from the scene during this time frame. We had 3 patient refusals. The health department engaged in 5 additional patients to some degree as well, for a total of 35 patients. Transport impacted 8 Baltimore City hospitals overall, and as Mayor Scott said, all patient care was successful. We did not lose a life that day, and I would also be remiss if I did not give credit to BPD for their interventions as well. There were officers in the street when we arrived attempting to resuscitate or revive patients through the use of Narcan. Is that yours?
Good afternoon, committee members. I'm Sarah Whaley, the Executive Director of the Mayor's Office of Overdose Response, and I'm going to talk about our on-scene response and how we continued outreach efforts. So following July 10th mass overdose event, the city maintained and continued an on-scene presence in the Penn North area with support from community partners for 2 weeks following the event. We were there also for a smaller second mass overdose event that occurred on July 18th. Shortly after the first event, in the hours following, we set up canvassing and outreach efforts that was coordinated between city agencies and community partners. These efforts focused the distribution of harm reduction supplies and education, with harm reduction messaging being focused on safe use for people that may have continued to use substances to prevent subsequent overdoses. This outreach was done through various channels, including through the mayor's office and the Baltimore City Health Department. Our on-scene response involved nearly 500 volunteers from more than 30 organizations, including representatives from the Maryland Department of Health and other local health departments across the state. We distributed approximately 4,500 naloxone kits, 2,600 fentanyl test strips, 760 xylazine test strips, and 600 hygiene kits were distributed. It was also the middle of summer, so we had food, water, and cooling buses on scene that were made available to community members in and around the field coordination site. As part of our response, we also included peers and other service coordinators who were available to do outreach and to canvass the area to help connect residents to treatment, housing, employment, and other services. From July 25th onward, a post-acute response was led by the Mayor's Office of Neighborhood Safety and Engagement, and you'll hear a little bit more about that later in this presentation. And I will pass back to Commissioner Taylor.
So let's go a little bit into the plan development. The timeline on this slide shows a high-level overview of the various events that informed the creation of the protocol from July to December. The city began working to develop the plan the day after the first mass overdose incident occurred. In October, another mass overdose incident occurred in Penn North. This time, we implemented several key changes based on lessons learned from the July response. These included, but were not limited to, 1, ensuring that outreach and canvassing teams always included at least one health department staff member, were clearly identifiable by wearing vests, and were equipped with radios to enhance communication and safety. 2, we also coordinated more closely with the state's Behavioral Health Administration. During the first response, the Behavioral Health Administration sent out an email blast to all overdose response programs across the state. While we appreciated this rapid support, we determined that the best order of operations would be for the Baltimore City Health Department to reach out to the Maryland Department of Health and for us to tell them exactly what kind of support we needed. And third, we also refined our system for looping in community partners for additional support. During the first response, we cast a very wide net for community partners. For October and going forward, we developed a tiered notification system for select community partners to be notified and asked to respond to the scene, which will help ensure an organized and streamlined response. The development of the protocol culminated on December 2nd, when all agency representatives working on the protocol met in person to finalize recommendations and resolve questions. Next slide. Here, you can see the objectives of the protocol. They are, number 1, immediate response and life-saving measures. This includes scene safety and security, rapid assessment and triage, administration of naloxone and medical intervention, and transport and medical surge management. 2, public health service delivery. The protocol aims to reduce overdose fatalities through education and naloxone saturation. It also aims to expand other harm reduction efforts, analyze and share public health data, improve access to prevention, treatment, and recovery services, and combat stigma. Last but not least, partnership and collaboration. The protocol emphasizes including trusted community partners in outreach response work and aims to enhance public health and public safety collaboration. This is exemplified in a unified command structure with Baltimore City Health Department and the Police Department serving as Joint Incident Command. Next slide. The protocol outlines a scalable, two-tiered activation structure designed to coordinate timely and effective response efforts based on the severity and scope of a suspected or confirmed mass overdose incident. The two levels of activation are partial and full. Partial activation will be triggered by 5 to 10 overdoses, and full activation will be triggered by 11 or more overdoses. The Baltimore City Fire Department will monitor conditions in the field and notify the Baltimore City Health Department whenever they respond to 5 or more overdoses within a 1 to 3 hour period. The Commissioner of Health or their designee will activate the plan. These activation levels are determined by real-time data and on-scene reports and provide a framework for situational assessment, communication, and operational coordination among response partners. Crucially, I want to emphasize that we are proactively and constantly conducting public health surveillance, monitoring, and reporting to prevent mass overdose events. These are core public health activities, and we have epidemiologists dedicated to that work. Next slide. For the partial activation, the response will use the Incident Command System, also known as ICS, which is the national standard for emergency response operations. During a partial activation, the Baltimore City Health Department will lead the response with support from BC Moore, the Fire Department, OEM, and the Police Department. Much of the response activity will occur within the operations section, which will include a triage, treatment, and transport branch, a medical monitoring branch, and a field coordination site to organize outreach and other services. Next slide. And then we go to the full activation. For a full activation, we will implement a unified command structure. In this scenario, both the Health Department and the Police Department will jointly lead the response. The same core services will be provided with the City Emergency Operations Center activated to coordinate resources and support operations. Both activation levels involve a high degree of coordination among participating agencies. And that's it for me. Thank you so much. I will now hand it off to Deputy Mayor Jaraza.
Great. Good afternoon, everyone. As you've heard reference, Mayor Scott actually activated the post-acute response the day following the event. And so while there was the immediate emergency response led by our public health and public safety partners, Mayor Scott activated this coordinated neighborhood stabilization response that was led by the Mayor's Office of Neighborhood Safety and Engagement on July 11th following the initial event. So after that acute response, the goal was really to mitigate trauma, to address the quality of life issues that we saw in the neighborhood, and to support residents, specifically our older adults who had experienced the trauma day in and day out. MONSE still maintains an on-site presence with community-based partners and service providers in the Penn North area at least twice a week. These partners include the Peace Team, New Life Recovery, and Never Take Life for Granted Recovery Housing. There are also ongoing partnerships with other city agencies, including our Department of Public Works, our Department of Transportation, and our Department of Housing to help address the environmental issues that we saw. In late July, MONSE and the administration actually engaged more than 200 people at an interagency resource fair. This included connections to behavioral health, substance use disorder treatment, harm reduction, housing, and other community supports. Again, MONSE has also supported with employment, having enrolled residents in workforce development with the Mayor's Office of Employment Development. MONSE even assisted a person who was experiencing homelessness that had lived in a nearby cemetery for 5 years get connected to shelter. And as I stated, they still maintain a very strong presence through the Peace Team, administering naloxone to a couple residents each day. In addition, as Commissioner Taylor noted, there have been hot washes to look at the ongoing response and to continue to identify areas for improvement. Next slide. So as we close out this presentation, one thing that I hope came through was how important interagency coordination was throughout our response. And that doesn't just stop with city agencies. We saw partnership with the Maryland Department of Health. We saw other jurisdictions reach out and ask where we needed support. And so when I think about other opportunities for this body to support, information sharing is critical. As we think about this response, how we were able to respond so quickly, that data sharing between agencies was crucial. That continued data sharing with the state, and we're already having some conversations with the state Maryland Department of Health, is really important as we make cross-jurisdictional decisions, because we know that this doesn't just impact Baltimore City. If we see it in the city, we're going to see it in other places throughout the state as well. Additionally, many of the initiatives that Mayor Scott has always supported, the decriminalization of paraphernalia, to just reduce barriers to individuals who are experiencing substance use disorder treatment, also is very important. Sustained investment in our rapid analysis of drugs program. And so if you saw on an earlier slide, there were multiple substances that were found in what people had ingested. It's important for us to know that so that we can share that with healthcare providers, we can share that with the community, and people can respond accordingly. And then lastly, of course, people with drugs, people who use drugs, having safe places to go for those ongoing supports, places where they won't be judged and that are stigma-free. Next slide. And that concludes our presentation.
Thank you for the presentation, and thank you for the work that you're doing to save lives. I have some questions. Let's start with Senator Reedy.
Thank you, Madam Chair. Thank you for this really great presentation, and really appreciated the detail. The issue of overdoses is something that just touches all of us, and we've seen it, my county and Carroll County. We've had issues for many years, and we've worked very hard to try to get a handle on it. But it's really, I won't say it's great to see, because obviously it's terrible what happened, but it's amazing that no lives were lost. I mean, it's just a credit to the care that all of you at the table and the agencies you represent took in this. I was curious, as you talked about how to analyze whether something is a cluster versus a not mass casualty, but a mass overdose. Do you have any ideas or recommendations for how those of us that have areas that are sort of rural and medium and small towns could adapt that framework so we could be keeping an eye on it? And if you don't have a specific answer, it's okay, but I was just curious how we'd scale it from a larger urban area to more of a suburban or small town type area.
Absolutely. So really, even for us within the city, we really had to work to refine our definitions. I would tell you all the time that you should start with your data and where you are seeing overdoses in your jurisdiction. Hopefully within your health department, you have some epidemiologists that can really crunch those numbers and geographically tell you where overdoses are occurring, what age groups they're occurring in, and everything of that nature. From there, you can really zero in on how often overdoses are occurring in your jurisdiction and within those discrete geographic areas. That's really what we had to do. You have to start with the data. You have to start with the people that this is occurring in, and then figure out from there, based on coordination with EMS and police, how often are they responding? How often are they doing naloxone reversals? How often are, unfortunately, you losing people to overdose? And then from there, you can decide for you and your jurisdiction, what is a cluster versus what is a mass overdose.
Okay, yeah, that's good.
And Senator, I just
Yes,
want
sir.
to add in, and thank you for the question too. I think it goes without saying that, but also knowing what's in it, right? It's very important to see if it's a cluster and connected. But then also, I think there's been a lot of conversation about how and where, people overdose, right? For us, there's been a lot because of this happened in Penn North outside, right? Everyone knew. But so many of our residents actually overdose in their own homes, right? And out of this work, we've also created a new program called Naloxone Neighbors, where we're empowering community associations and presidents and leaders to be trained and have that stuff available, because we have to think about, and for you all, that's something that I think you really should think about, because you don't have a lot of places where there are a whole bunch of people outside in this case, and I just wanted to raise that for
No, I
you.
appreciate that. That's really good advice. And the last, just sort of, I guess, mini question I would have is, I noticed when the mass overdoses happened, a couple of them right back to back, and then one in October. Did we get to the bottom of what the product was? I saw some reporting on it, but I never heard the font. Did we get to the bottom of what the product was, and is it? I know it's like whack-a-mole because there's always new crap coming on. No, excuse my language, but.
Yeah, Senator, we can talk about that offline. This is all part of an ongoing police investigation, so we
Gotcha.
don't want to get into details about that.
I appreciate it. Thank you.
Vice Chair Hayes.
Thank you, Madam Chair, and thank you all. Thank you, Mr. Mayor, Madam Deputy Mayor, our Health Commissioner, Police, Police, Fire, everyone. One of the reasons, and thank you, Madam Chair, for allowing us to come today. I think Senator Reedy, one of the reasons why I asked him to come here was just for the reason that, you articulated. Not everyone represent, an urban, dense area like Baltimore, but I remember conversations a year ago where people thought, the opioid epidemic was just isolated to Baltimore, right? And then since then, it's spread all over the place. And, I'm concerned that, we had it in Baltimore, but the potential of it happening in other places throughout the state is very great. And so just want to make sure that our jurisdictions, no matter where it is in the state, is prepared in this case. It's interesting. When I was in the House, we established the first of its kind stabilization center here in the state, and I had a chance to visit it soon after one of these overdoses. And I learned from them, some of the more common street drugs like heroin, that I thought people would still take, it's not even on the streets anymore. They test everyone that come in, and the substances that people are using range widely. And so that was kind of an eye-opener for me. I'm not sure if anyone could speak to this, but anecdotally, we kept hearing a lot of the folks that fell victim, some of them weren't from Baltimore and weren't from the area or whatever. And I think when you're looking at the data, and I'm not sure who records it, whether it's, local health department, push it up to the state, but is there any work done to see like the last known address, so to get a better idea on the epidemiology side on like where people are coming from and experiencing this? So, because I believe if we had that information, MDH and others could better deploy or have conversations and resources in those jurisdictions. Is that information available?
That information is somewhat available. So a lot of times what happens with us as a local health department is a lot of the information that we collect on folks who have experienced an overdose gets funneled up to the Maryland Department of Health. They make sure that they know where the overdose occurred, but also if they can determine where the person is from, they also record that as well. And then that information gets passed back down to the jurisdictions for those individuals. With that said, there are a lot of data use agreements in place where there are some things that we cannot share publicly as a local health department because it is under the purview of Maryland Department of Health to release it. But I'm happy to report, and Dr. Jaraza alluded to this, we're having talks with the Maryland Department of Health now to make sure that we can share more information publicly, not only about what's going on in Baltimore City, but really start to get at some of those questions that you just asked.
Even if not publicly, is like in your data sharing agreements, is MDH, are they allowed to share the information on where the last known address of the person with the local, not even publicly, but internally amongst local health departments in the state?
Internally, potentially, but I don't want to misspeak. There may be some rules around that as well, and especially when counts are super low. So say, like my colleague here in his district, if he only has maybe 5 overdoses in a year's time, and there's a potential that you could identify any of those folks, then those overdoses, those people's data would be suppressed for their protection of their information.
Right. I think it's good that you all are having this conversation with MDH and trying to find ways or whatever. I would imagine it would be, that's obviously a potential place where we could improve communication. But if there's others, would love to find out more at some point so we can help improve this, especially as it relates to other jurisdictions out the state. But again, job well done, and thank you all so very much.
Yeah, and Senator, you know how data-driven I am, right? And we would love to have a further conversation about that, even if it's just some notification from MDH to that jurisdiction that doesn't necessarily have to come back to us. We just have to figure out ways to protect people's information, but also protect public safety.
Thank you, Mr. Vice Chair. I don't see any other questions. Thank you very much for your presentation and your work.
Thank
Have a good afternoon. Thank you. So, committee, we're going to have just a few-minute break while Tammy switches to our bill hearing.